I think we're ready to get started with our next presentation. We have Dr. Ben Wormser from the Maryland Department of Health and Andrea Augustine from the Maryland Department of Health. And today they're going to be talking about modernizing the maternal care coordination in Maryland. So I'll turn it over to Dr. Wormser.
Thank you very much, Kevin. And it is wonderful to be with all of you this morning. My name is Ben Wormser. I'm the Medical Director of the Maternal and Child Health Bureau here at Maryland Department of Health. I'm a general pediatrician, and I'll be presenting along with my colleague, Andrea Augustine, who will introduce herself in a few minutes. And today we'll be talking to you about the Integrated Maternal Health Services Initiative. Just a brief overview of our agenda here. So we'll set the stage for some of the context for this project with our maternal morbidity and mortality in Maryland. Then we'll talk about the Women's Health Action Plan, which is our statewide strategy for addressing morbidity and mortality in the perinatal space. And one of our key interventions in that plan is perinatal care coordination. And so we'll talk about that and then how the Integrated Maternal Health Services Initiative is modernizing perinatal care coordination in Maryland. Next slide. So as I mentioned, Andrea and I are from the Maternal and Child Health Bureau here at MDH. This is our vision, mission, and values. And our tagline is healthy pregnancies, healthy children, healthy families, healthier communities. And that's our goal every single day. That's what all of our work is directed towards. And we're very excited about this work in particular. Next slide. Now, as many of you are likely aware, there is a maternal mortality crisis in our nation. Right now in the US, there are 23.5 maternal deaths per 100,000 live births, which in Maryland, it's a little bit lower. It's 20.5 deaths, which places us 18th out of the states in the US. But it is still well above our Healthy People 2030 target of 15.7 deaths per 100,000 live births. And honestly, I think we can all say that one death is too many, and it's something that we're going to be always trying to prevent as we work through this system. It's also notable that if you look at our curves here of maternal mortality, we have had persistent racial disparities, where the yellow line representing non-Hispanic Black birthing people has been persistently higher than non-Hispanic white and higher than the state average in general. And that is related to system factors that we have created as a society and that we are working to try to reverse right now. Next slide. Those racial disparities persist even when you take one step lower than mortality and you look at something called severe maternal morbidity. And these are a collection of specific diagnoses of an unexpected severe event during the perinatal period. So things like myocardial infarction, amniotic fluid embolism, sepsis, obstetric hemorrhage. You will see that the red line now representing non-Hispanic Black birthing people is also persistently higher. And then it's been really hard to get any of these trends in a downward direction. Next slide. So what is the state doing about this? We have a Women's Health Action Plan, which launched in 2024, and it has the goal that all women will achieve optimal health and well-being and have the agency to make choices regarding their bodies and reproductive and sexual health. Next slide. It has 6 overall goals. First is to protect reproductive rights and expand access to reproductive health services, including abortion care. Second, to advance birth equity with a focus on Black maternal and infant health through the perinatal continuum. Third, it's to support behavioral health needs across the life course. Fourth, to improve access to comprehensive high-quality somatic services throughout the life course. 5 is to increase place-based and community-centered approaches to promote health and prevent disease. And finally, to expand, support, and diversify the perinatal workforce. We'll go to the next slide. Now, infused in several of these different goals, but especially the place-based supports goal, is perinatal care coordination. And for those of you that are not familiar with perinatal care coordination, I'll explain it this way. If you envision the perinatal experience as this dark blue arrow, where a birthing person is going to their prenatal provider for regular visits, maybe that's an OBGYN or midwife. Eventually, they go into labor and deliver at a birthing hospital or wherever they've chosen to deliver. And that is sort of like your standard clinical care. But in Maryland, we do something called perinatal care coordination, which is run out of our local health departments and our Medicaid managed care organizations. And this is sort of infused throughout the entire perinatal experience, helping to link patients to community-based supports in between and in coordination with the clinical healthcare that they're receiving. And it starts in the prenatal period and goes into the postpartum period. These supports range from social support like transportation, food security, housing assistance, community support like connecting with a doula or home visiting program, diaper banks. We can help to connect them with behavioral health care, and that's sort of in collaboration with their clinical healthcare teams. If there's other healthcare that they need that they're having trouble accessing, like dental care, we can help to support that. And then also once the baby's born, making sure that they have a pediatrician, that their immunizations are up to date, that the birthing person has sufficient breastfeeding support, et cetera. All of this can be run through the local health department and the Medicaid MCO. Go to the next slide. Now, sort of behind the scenes, operationally, which is really where the focus of our conversation is going to be today, this is achieved in two ways. First, historically, there's been a prenatal risk assessment, which is a paper-based form that the prenatal provider fills out. It has some of the patient's information, some of their risk factors for their if they have any for their pregnancy, and that gets faxed to the local health department. The birthing hospitals, once the baby is born, will also complete a postpartum infant and maternal referral form to connect and fax that to the local health department to connect the birthing person and their family now with the local health department and their MCO. And then the local health department takes that information, conducts outreach to the patient in their community. So it's somebody from their community talking to them in their community and connecting them with supports that are located in their community. That's how it's supposed to work. And that's how it was designed on a paper-based system. But if we go to the next slide, if we kind of take the next layer of the onion back, and some the actual specifics of this slide don't matter so much as to say that it is a very complicated process where there's actually an entirely different unit within the local health department called an administrative care coordination unit that's receiving some of these forms, whereas others are being sent to a different part of the local health department. The MCOs, the local health department, and these community-based organizations are all communicating and supporting each other in providing care for the patient, but it's all done over fax. And as you might imagine, a lot of communication can get lost. There's not great feedback loops. You send something off and you have no idea if it was received or if the patient got their services. And so that's what the Integrated Maternal Health Services Initiative is aiming to improve. If we go to the next slide. We found that when we looked at our data back in 2021 and 2022, only about 30% of those who are eligible for having an MPRA completed were getting it actually completed. It's only about 30% were getting access to this amazing Maryland resource. There was also highly variable PMR completion rates in the hospitals where some hospitals were doing a pretty good job. They were sending it for most of their eligible patients, and other hospitals were sending none. And so we knew that we needed to make some changes to try to improve the system. So we wanted to work with CRISP, which is already integrated with all of our clinical providers across the state, to try to make this referral system digital instead of paper. And the advantages to that were that first off, any future updates to the MPRA or the PMR form would automatically be updated in CRISP, and we wouldn't have to distribute it to all of our different partners. We could create required fields, which would increase the amount of the questions answered and the usefulness of the forms when it's received. You'll have that more reliable connection. When we send it, we know it's going somewhere. And now there's also an opportunity for a feedback loop so that the clinical provider, when they complete the form, actually gets updates on what the status of that referral was. And finally, it's really just an effort to integrate with the digital delivery of healthcare more broadly and make sure that this is part of the clinical workflow for all of our prenatal providers and hospitals. Next slide. So this brings us to the Integrated Maternal Health Services Initiative, which is a HRSA-funded grant that we received to really try to modernize our entire perinatal care coordination system, of which a part is this work with CRISP. And for that, I will pass it off to my colleague, Andrea Augustine.
Good afternoon, everyone. As Ben said, my name is Andrea Augustine, and I am the Perinatal Health System Specialist with the Integrated Maternal Health Services Initiative, IMHS. I am delighted to provide you with an overview of IMHS and the story of our transition to the CRISP platform, including its design, implementation, the outcomes, and what lies ahead. Next slide, please. Given the contextual factors Ben illustrated, IMHS was conceived as a demonstration project to consolidate those disparate EMPRA and PEMR components and features of the existing care coordination systems into an integrated model that brings together HIE, Medicaid and its insurers, community clinical providers, hospitals, LHD care coordination staff, patients, and representatives of community-based organizations as collaborators to design a data collection, management, and dashboarding system that works for all stakeholders who use either form. The primary objective of this project is to improve the rates at which high-risk pregnant and postpartum people identified by their care team are connected to services in their community. And then a longer-term secondary objective is to understand the impact of the EMPRA and PEMR completion on maternal health outcomes, including maternal mortality in Maryland. These objectives should ultimately lead to evidence demonstrating the impact of the forms on maternal health and health equity. Next slide, please. This slide illustrates the jurisdictions that currently participate in IMHS. They are Prince George's County, 8 counties on the Eastern Shore, which are Caroline, Cecil, Dorchester, Kent, Somerset, Talbot, Wycomico, and Worcester County, and our most recent addition, Baltimore City, who joined in July of last year. Next slide, please. There are 5 key phases in IMHS. The first phase, which I will describe in more detail momentarily, was the creation of the digital PEMR and EMPRA forms. Because we digitized the EMPRA first, the next step was to launch it and increase utilization among program partners. We then rolled out the digital PEMR and focused our attention to its uptake. Because CRISP broadened our understanding of patients' perinatal care pathways in real time, as well as the gaps in care coordination, we directed our attention to enhancing the system-level quality of perinatal care coordination by closing those gaps. We are also simultaneously in the public awareness campaign stage, working with a communications vendor to develop and disseminate targeted messaging to promote IMHS. Next slide, please. IMHS would not be possible without the support of the various partners listed here. Chief among them, our funder, the United States Health Resources and Services Administration. Next, given IMHS's focus on Medicaid recipients, Maryland Medicaid. Then we have the Administrative Care Coordination Units, otherwise known as ACCUs, and the public health teams at the 10 local health departments that I listed earlier, in addition to 9 Medicaid managed care organizations. Together, they all receive and manage the digital referrals in CRISP. And lastly, we have the various implementing partners, such as CRISP itself, who also play an essential role in the project's implementation. Next slide, please. IMHS is guided by a coalition known as the Perinatal Risk Advisory Working Group, or PROG for short, which includes representatives from MDH's Maternal and Child Health Bureau, Maryland Medicaid, local health department care coordination staff, ACCU staff, that's Administrative Care Coordination Unit staff from the participating jurisdictions, leadership from participating birthing hospitals and pregnancy care practices. Our QI contractor and I staff the PROG, facilitating its monthly meetings and addressing project priorities. This group helps shape the process of digitizing the forms, how we incorporate data, and how we close the gaps in care management. Next slide, please. Our QI vendor also manages the Patient, Family, and Caregiver Advisory Group, whose members are birthing people and their families who are current or recent recipients of perinatal care in the IMHS service area. This group also meets monthly to share their lived experiences and to provide feedback on how the system could be improved. Next slide, please. This last group of stakeholders is tasked with increasing coordination within the IMHS region. They guide the PROG on the ongoing development of policies and procedures for the statewide rollout of EMPRA and PEMR forms and the practices required to support referral pathways for vulnerable populations needing perinatal care. The regional coordination team members also will build critical relationships with other clinical practices and IMHS partners in their respective region. Next slide, please. And now we begin the story of the transition to the digital EMPRA. Before developing the digital EMPRA, our QI contractor conducted an environmental scan of the existing context of perinatal risk assessment workflows in Maryland. This scan, known as a Knowledge, Attitudes, and Practices Assessment, or CAP assessment, consisted of surveys, focus groups, and key informant interviews with clinical staff, staff from local health departments, and administrative care coordination units, as well as patients and family members served by the risk assessment and care coordination system. The CAP assessment findings, included myriad challenges inherent in the paper-based environment. As Ben mentioned earlier, the paper-based system was fraught with challenges. Forms were often incomplete, inaccurate, or illegible. They were also transmitted inconsistently, where some providers faxed them upon completion, while others would do batching, which is faxing them after accumulating a substantial number. Additionally, the paper form lent itself to fragmented communication and EMPRA reimbursement across the system of care, and it was widely considered to be a burdensome and/or redundant process. These findings directly informed our development of the electronic version of the EMPRA. We worked with CRISP to ensure that the interface of the form and the referral it generated worked well for all end users. Because IMHS also has its own set of HRSA-mandated data requirements, we collaborated with CRISP to design workflows that synchronize the trajectory of patient care coordination, referral management in CRISP, and data collection. We also developed training materials that captured these complexities and coordinated approaches to providing technical assistance, while our QI vendor met the workflow support needs of the clinical sites that submitted the EMPRAs. While the launch of the digital EMPRA was successful, despite the size and complexity, it was not without flaws on the user and device side. As with all technological innovations, we experienced unpredictable glitches. For example, some patient data was not uniformly visible at the local health department and MCO levels, despite being included on the forms that were submitted. Other issues included limitations on what users could enter due to text field sizes, as well as misalignment with the paper form. On the user side, some clinical providers continued faxing paper forms while simultaneously submitting them electronically. While the intent was to ensure receipt, it created confusion and backlog on the receiving end. Similarly, many EMPRAs were still incomplete because users skipped what appeared to be optional fields. Next slide, please. Given our experience with the rollout of the digital EMPRA, we decided to pilot the PEMR on a smaller scale first. Secondly, Chris' deep expertise, coupled with the strong feedback loop with our users, enabled us to coordinate rapid responses to any glitches or challenges. We also made adjustments to the structure of the form to enhance user visibility across the board and to prevent incomplete data entry. Next slide, please. We applied the lessons learned from the digital EMPRA to the development and implementation of the digital PEMR. For the pilot, we selected a birthing hospital that submitted at least 10 PEMRs a month. This led us to Prince George's County and the respective local health department. We began on July 1st and closely monitored the process. Initially, the pilot was slated to last for 2 weeks, but we added an additional week to ensure the readiness of all implementing partners. So then we rolled out on July 21st. Building on our experience with the EMPRA, our QI vendor established regular drop-in hours for clinical providers to share their feedback or raise concerns. Whenever challenges arose, our vendor arranged virtual meetings with CRISP to troubleshoot the issues in real time. Lastly, our vendor worked with CRISP to create a cheat sheet, giving guidance for frequently asked questions and common challenges. Next slide, please. The lessons learned from our PEMR experiences were various. What was interesting about the PEMR is that the LHDs were actually, the local health departments, that is, were actually very instrumental in enhancing provider awareness and understanding around PEMR submission. Whereas the EMPRA was historically required for Medicaid patients, the same was not true for the PEMR, which is available to all patients regardless of insurance status. Many local health departments directly engage with providers to increase their submission. Secondly, because the PEMR is not a Medicaid form, they were never routed to MCOs in the past. This created missed opportunities for enhanced care coordination. Participating MCOs now receive them for Medicaid patients and provide critical services to their patients as a result. Next slide, please. Here is a screenshot of views of the digital PEMR and the EMPRA, which were built to mirror the paper versions as closely as possible, but include features to enhance the quality of the data they capture. Next slide, please. Earlier this year, our QI vendor conducted a follow-up CAP assessment to assess the clinical submission workflow environment with the advent of the digital forms. The top finding is that the digital forms were found to be easier to use, reducing the redundancy and burden associated with the paper form. The next finding was that birthing hospitals and prenatal practices all experience varying factors that determine whether submission is centralized or distributed, performed by a clinical staff person or a non-clinical staff person, and so forth. As a result, the development of site-specific workflow solutions is key. Lastly, the digital form environment holds great promise for a more integrated system of perinatal care coordination. It has already strengthened communication across partners and lends itself to shared accountability, data, and expectations around perinatal care coordination. Next slide, please. Another source of pride that emanated from this project are two data dashboards that CRISP designed. One illustrates patient data at the aggregate level, and another illustrates individual patient data. These dashboards are available to users depending on the user type and their function. But most importantly, with these dashboards, we now have stakeholder accessible digital platforms that collect referral data and perform analysis of trends in referrals, follow-up, and outcomes. Once again, accelerating the integration of perinatal care coordination to better meet the needs of Maryland's birthing people. Next slide, please. Thank you. That concludes my presentation.
Awesome. Well, thank you so much, Dr. Wormser and Andrea. We do have a bunch of questions in the chat that I will read out and allow our speakers the opportunity to answer them. Keep asking your questions there. If we can't get to them, we will follow up offline. I did want to point out a clarification with the CME credits. MPs and PAs can submit the evaluation form. We just got a note from our vendor about that, so go ahead and submit that form if you would like to apply for a certificate. It is available in the resources sections or the lobby of the session here today. All right, so let's cover some questions. I'm going to skip to this one because I think this one is a good one. When will the digital forms be available to the rest of the counties still using paper forms?
Oh, thank you for that question, and it is one we get often. So we are planning to begin the statewide expansion in state fiscal year 27. So starting in July of this year. There is a decent amount of setup that needs to be done at the local health department first, and then sort of reaching out to each of the clinical providers to make sure that they have the right access to this CRISP form, know how to use it, et cetera. And we have, as we've been doing this rollout of the digital MPRON, PEMR, and CRISP, we have simultaneously been developing toolkits and resources to really make it easier and more streamlined for onboarding of clinical teams and the local health departments. So all of that is to say we've waited until July of this year to start that outreach or that rollout, and it will start in just a few jurisdictions and sort of build from there because we wanted to make sure that there was adequate support to do it before actually starting.
And I think this question kind of ties to that answer a little bit. On average, how long does it take sites to get set up with a site-specific digital solution?
That's a great question. I don't think we've really measured it from a timeline standpoint. I think there's sort of several different steps. There's first making sure that you have the right access to CRISP and to this form, which the CRISP team has been fantastic with, and that's really as simple as sort of connecting with your HIE expert and then doing a training with our CRISP team that is a 1 hour training, and you pretty much have that piece ready to go. But then what we've been working with, Andrea mentioned our QI partner, who is Primary Care Coalition. They've been doing a lot of quality improvement work on the ground with our clinical teams because we wanted to make sure we understood the best ways of integrating this digital form into their existing clinical workflows, or maybe slightly tweaked clinical workflows, so that it's just a natural part of your delivery of clinical care that you're also doing the MPRA and PMER. And I think that it's that piece of working it into your clinical workflow that is highly variable in terms of the amount of time it takes. It may be as simple as the person who does the form now does it online versus on paper, but for other teams, they really restructured sort of the way that information flows within their clinic to make it easier and to sort of help match the flow of the patient care. So that in that way, it's a little bit variable.
Awesome. Will this grant also facilitate the interfaces of EMRs with Maryland labs to ease the burden of getting newborns labs back as well as other labs?
The newborn screening lab or the newborn screening follow-up program is in the Maternal and Child Health Bureau. The lab is a separate part of Maryland Department of Health. Unfortunately, this grant will not be supporting that, but I do know that that is an interest, because as a pediatrician, I too have had to hunt down newborn screening results, and the team is working really hard to make that much easier.
And then I think we have time for one more question. Carol asked, you mentioned a communication vendor for targeted messaging. Do you have the name of who you're working with on this, or how are vendors being vetted?
I can get the name. Sorry that I do not remember it off the top of my head. We work with so many different partners and vendors, but happy to share that at a later time.
Yeah, and they're all selected through our state procurement process.